Thank you for inviting me this conference. So my title is Bifurcation Lesion Current Update. This is a baseline assessment of bifurcation anatomy. Regardless of the stenting technique chosen, the initial step for successful bifurcation PCR strategy begins with a good understanding of bifurcation anatomy. This is very important. The main points when assessing bifurcation anatomy may be summarized as follows. Assessment of the 3 diameter of bifurcation, main branch, proximal main branch, distal main branch, and the side branch diameter. Second, assessment of the lesion length and the plaque distribution. Finally, assessment of the bifurcation angle and side branch osity. So this is a famous classification of a bifurcation lesion, mediana classification. As you know, 3 components, 3 parameters, main branch, and side branch. Through bifurcation lesion, as you know, 111 or 101 or 011. So LMT lesion is quite different than the bifurcations. This slide is the difference between the LMT and the other bifurcations. So LMT has a large reference diameter and the T-shaped bifurcation angle, and a circumflex takeoff may impact on prognosis after LMT stenting. And proximal main branch originated directly from the aorta is a very important thing, and it means longitudinal compression during left main stenting is common, and when untreated is associated with adverse outcome. And finally, important thing is the proximal reference diameter may reach 6 millimeter, which is close to the dilatation limit of many coronary stent. So this slide, same slide, the unique features of left main bifurcation, the paper in Euro Intervention 2015, osseous position of the main vessel, and large size of the side branch, and calcification is frequent. Blunt bifurcation angle, this means T-shape, and crucial role of pot. Pot technique is very important in LMT lesion. So today's agenda, bifurcation stenting, we should consider before PCI. First, stent strategy, 1 stent or 2 stent should be selected. And the stenting process technique, guide wire crossing point, pot technique, and the KBI. And very important thing is possibility of a presence and extent of jailed strut and malposition. Both jailed strut and malposition are independent risk factor for the clinical course. And the 2 stent technique, provisional T stent, pilot stent, DK class, and so on. Finally, let's talk about stent design, for suitable stent design for bifurcation lesion. So first, stenting strategy. So ESC guideline tell us class A and level A is 1 single stent in main vessel only, followed by provisional balloon angioplasty with or without stenting of the side branch in recommended or PCR for bifurcation lesion. But in some case, 2 stent strategy should be selected. It means side branch with complex and extensive stenosis more than 5 millimeter disease extending into the side branch. And another case, guide wire is very difficult to control in side branch branching. In that situation, we should take a 2 stent strategy. The most often used electro 2 stent techniques are kilot stenting and DK class stenting. Later, I explain. So next theme is stenting process technique. This is very important. Guide wire recrossing point and the pot technique and KBI. So first, guiding catheter selection. 6 French guide catheter is generally used. However, in some cases, 7 French guide catheter may be preferred when complex 2 stent strategy are planned. So later, I explain 7 French catheter, 6 French guide catheter, as we call it, 7 French catheter is a thermo-blood sheath technique. Later, I explain. So this strategy is very important. Essential technique for bifurcation stenting, lesion preparation, pre-kissing balloon KBI technique, especially hard plaque lesion, and pot technique, guide wire recross point, correct point. KBI after stenting. So pre-dilatation, the EBC, Europe Bifurcation Club recommends pre-dilation as only of the main branches. Routine side branch pre-dilation is not recommended unless side branch access is difficult and severe diffuse and calcification region and the flow is compressed after wiring. In that situation, side branch pre-dilation is needed. So this is a pre-kissing button inflation is needed as a true bifurcation reason to avoid cardiac shift. This is very important. Panel A is true bifurcation region, as you can see. If we take a balloon dilatation at only main branch, cardiac shift and deformation at the shoulder of cardiac is occurred here. So in that situation, comparison the plaque at compression to compress the plaque at the carina due to KBI is needed. In such a situation, kissing balloon inflation is needed before stenting. It's very important, especially LAD and diagonal branch bifurcation here. In some cases here, the shoulder at the diagonal branch has usually had a plaque. So possible mechanisms of side branch compression, especially if calcification, there is calcification position at the opposite side branch. In that situation, if we put the stent, cardiac shift is occurred because carina without athletic change is seen and easy to shift toward the side branch and result in osteostenosis. The existence of a large calcified plaque opposite to side branch leads to stent expansion to towards side branch because of elastic characteristics of athletic plaque. This mechanism may play a role in cardiac shift. It's very important thing. This is some representative case. Calcified plaque at the bifurcation. Panel A is angiography. This is a bifurcation region. And A, B, C. At C point, this is the OCT image. Around the LAD, there's a much calcified region, except the diagonal branch. Angioplasty at the pre-stent inflammation showed LAD bifurcation region. OCT demonstrated the severe calcification is LAD bifurcation region. After stenting, in that situation, after stent implantation in LAD, angioplasty and OCT disclosed stenosis at the side branch OCT. This is a cardiac shift. So, in that situation, true bifurcation with calcification. In that situation, pre-KBI with hard squaring balloon is recommended because to compress the plaque around the carina is a very important thing. So we know why we kissing. Apart from the obvious answer is to create the carina and prevent cardiac shift here. So wiring, next time I need to talk about the wiring. The ABC recommends the jailing wire technique, which consists in leaving a wire in the side branch while implanting a stent in the main branch. It means position advantage here, for advantage. It's very important thing is second, it facilitates access to the side branch by favorably changing the angle of the bifurcation. This is very important. And the next important thing is number 3. The jailed wire is a modality of anchoring that facilitates the intubation of the guiding catheter, providing a firmer support of the balloon to cross the original of the side branch. They're very important. So next, the main branch stenting. Drug-coating stents are recommended. Stent size is very important according to the size of the main branch beyond the bifurcation, as this reduces the risk of side branch occlusion caused by cardiac shift and dissection within the distal segment. It's very important thing. So next essential technique for bifurcation stenting is a pot technique. What is a pot? As you know, proximal optimization technique is being a pot. As you can see, balloon after stenting, next balloon dilatation here, large balloon dilatation. They move this edge of the stent to here. This is very important. So finally, after pot stenting, a pot technique, stent slot is enlarged here. It means positioning of the short non-compliant balloon with a distal marker in front of the carina and the proximal marker inside the proximal stent edge is important. This is important tips. So this is the first question. pot why do it to optimize result in the main branch and reduce obstruction to the side branch, and finally, to prevent guide wire tracking behind your stent during recross. It's very important. This is a micro MRI imaging. After pot technique, usually stent over stretched, and the easy go to the far distal. So proximal optimized technique should be performed routinely after main branch stenting. And the non-compliant balloon is recommended. And the diameter balloon size is 0.5 or 1.0 meter larger than the main branch stent diameter. Length is very important. The smallest length of a commonly available balloon. It means 6 millimeter or 8 meter length balloon, non-compliant balloon is recommended. And a very important thing is positioning of the short non-compliant balloon with a distal marker in front of the carina and the proximal marker inside the proximal stent edge. A very important thing. This is a example case. This is a osteomolar LED lesion. This is an AP quadrant view, and this is a RA cranial view. And first, we put the stenting mid-circumferential position, and then we treated elementary region. So first, put dilation at the diagonal branch with a 2-hole balloon, and put dilation at LAD with 3 millimeter balloon, and check IVAS mark. This is a IVAS marking at the distal stent landing zone, and this is a proximal landing zone. This is a Japanese style. And check IVAS. IVAS tells us around the bifurcation lesion, especially diagonal branch and LAD, there's much plaque here. So we decided to put dilatation before stenting both diagonal branch and LAD. Diagonal branch coming here, this is 8 o'clock. So we decided to put a KBI because this is a true bifurcation lesion, and to compress a plaque around the carina and to avoid the carina shift here. This is the same image. So KBI before stenting to compress a plaque around the carina, and then we put the stent, 3 or 33 meter stenting, as followed by stent IVAS marking imaging. This is a stent dilatation. This is a CAG after stenting, and then we put technique with 4-5 MC balloon. But this is the same image. This is a pot is too deep here. It's a pot, balloon position is here, very difficult, very important. Don't pot technique is too distal, it's very important. This is a CAG after pot technique. As you can see, ostial circumflex is gelled. So recross guide wire with another wire. This is I like Lancel hypercoat. Lancel hypercoat guide wire has hydraulic wire. So it helps to, it's very useful to cross a stent strut, very easy. So this is a rewiring technique. Side branch rewiring is required in case of the need of further intervention. The following main branch stenting, side branch is rewired with the main branch wire before removing the jet wire. The IVAS check to check a guide wire recross point. Correct recross point is far distal stent strut. It means we check from IVAS from LAD, first recross guide wire here, and then circumferential lumen. It means this is a far distal stent. Guide wire come here, and then lumen. It means recross guide wire is positioned at the distal far side. It's very important, the IVAS imaging. And then balloon dilatation. But 3-hole balloon for circumflex cannot cross. In such situation, slipping balloon technique is useful. First, balloon dilatation at LAD. In this case, 4.5 balloon dilatate at LMT and LMT from LAD, and immediately deflation and deflate the 4.5 balloon and immediately 3.5 balloon push. The easy balloon slips across the circumflex here. This is a slipping balloon technique, and then dilatation 3-hole balloon. Finally, we should perform a kissing balloon inflation. I like a mild kissing balloon inflation at the most 8 to 18. to avoid the stent malposition. Finally, this image here with the finally IVAS here. So no jailed stent strut at the bifurcation is very important. If stent jail here, jailed strut is a risk of bad clinical course. This is the final image here. So next, important component, possibility of presence and extent of jailed strut malposition. This is a second question. Side branch strut opening or leave alone, not opening. So this is a Corbis-3 study. This is a blue line is a side branch opening. It is in KBI. Red line is not KBI, leave alone. As you can see, TLF, cardiac death, TVMI, TLR, is a no difference, no significant difference between two groups. And multivariate analysis tells us no difference, the TLF between two groups. Really? And this is my question. So if we perform a KBI, wire recross point is very important because influence of a main vessel stent cell rewiring on stent deformation when kissing angioplasty. This is a distal wire crossing before KBI. Right panel is a proximal wire crossing right panel. As you can see, after balloon dilatation, the circumference or KBI, good scaffold, so the circumference OST. But if wire crossing at the proximal point, no good scaffolding for the OST of the circumflex. So Carina provides better scaffolding of the origin of the side branch is at the left panel. It's very important thing. And the impact of recrossing wire position on shear stress after ballooning. Panel A, far distal side. Panel B, proximal side. After KBI, on the panel B, this is a stent strut remain. This is a jailed strut. In such a situation, shear stress is no good here. This is the risk of bad clinical course here. Jailed strut is independent risk factor of TLR and MACE. Either side branch open depends on the wire recross point. So we should be careful to check the recross point of guide wire. It's a very important message. So desired recross point far distal at the bifurcation to avoid stent strut jail. This is the two chips for recross, imaging device support, and the wire movement here. So our OCT or OFDI or IVAS imaging is helpful. It's very helpful to check the recross point. And the bifurcation probably recommend verify your position in side branch recrossing and rule out of accidental abdominal rewiring essential in two stent techniques. So this is an OCT or OFDI image. If guide wire, recross guide wire to cross at the distal side after KBI, the good balloon opening, and there is no jailed strut. However, if recross guide wire recross the proximal side as after KBI, then jailed strut is here. It's very clear in the image. But however, angiography is limited in recognize a recrossing wire position here through the proximal cell or distal cell. I don't understand it. But OCT is very clearly here. This guide wire is more proximal side here. OCT or OFDI image is very helpful. So if proximal wire crossing after KBI, this is a stent strut, jailed strut here. But if distal wire crossing is a very good open, there's no strut jail. This is an OCT or OFDI image. The offline assessment is useful of recommend a recrossing point is here. Upper side panel A is guide wire. It's recross the far distal. After balloon dilatation, here, the very open here. Very clear. And this case, the OFDI case, guide wire recross first attempt to here. This is a proximal side. But here, again, we try to the second attempt in this paper. Side branch guide wire at the distal side, optimal side here, very clearly. After balloon opening, good result here. No jailed stent strut. So second tips for recross wire shape. After pot, wire shape need to recross the stent strut is large shape is better. Without pot, shape length is distal LAD plus 1 or 1.5. But after shape, optimal length, these are LMT size and 1 plus 1.1, 1.5 millimeter. It's very important. After pot, the length of wire shape is large. And second tips for recross guide wire. OCT, OFDI image or IBUS image is very helpful to check a recross point. But if in situation with no imaging guidance, wire movement is very helpful because if guide wire recross the far distal point, guide wire to go to some branch here, the wire push, the wire attached to the carina. If guide wire is close at the far distal, we should put the guide wire slightly because in this situation, the guide wire could touch the carina at bifurcation. But if guide wire recross point at the proximal side, wire push, but wire don't touch to the carina. This is a good technique without imaging devices. So bifurcation stage on the one stent strategy is finally kissing is NC balloon inside the branch or main branch because good position and good scaffolding of the circumflex. And the J strut is independent risk factor of TLR maze. And suitable KPI is needed for good clinical course. So EPC update formats, 3 letters for ballooning techniques that can be applied to both single and double stent. First, pot, and dilated only side branch, and finally, kissing balloon technique. So if we dilate the only side branch dilatation, as you can see, stent malpositions occurred to opposite sides of side branch here. So to recover the situation, finally kissing balloon technique is important here to avoid the malposition, center malposition. Finally here. So usually with a provisional side branch technique, and some case gelled balloon technique is useful. Gelled balloon technique, as you know, gelled balloon at the side branch still remain during stenting in the main branch. After stenting, side branch balloon dilatation at a small atmosphere, and then balloon removal, and then wire crossing to avoid the side branch occlusion. And recently, modified Z balloon technique here. Usually, Z balloon technique is balloon positioned here, but modified Z balloon technique is here, more distal, to avoid the main branch stenting disturbance. So here, more distal side to avoid the stent deformation on the proximal side. This is an example case. It's a LAD bifurcation lesion. After wire crossing, we check IBUS, and this is a side septal branch here. This case, this patient has intervening function is very low. It means to protect the side branch is very important. It means especially large septal branch is very important. And around the septal branch, there are much plaque here. It means if we put the stent is only LAD, maybe side branch disappeared. So we decide to play KBI for LAD and septal. And then we try the gelled balloon technique as septal branch and the 2O balloon. And after stenting, here. Septal branch is a 2O balloon still remain. And then we balloon dilatation at 2 atmosphere, small atmosphere. And then balloon pull out, gelled balloon. So guide position is very important because counteracting during the balloon pulling out here. And then after the balloon technique here, the septal branch is not disappear. So wire recross to the septal branch, very easy. And post dilatation at the LAD 3.5 millimeter balloon. And we tried to the 2O balloon again, a 2O balloon to deliver the septal branch again. However, it's very difficult. In such situation, slipping balloon technique is very useful. 3.5 balloon dilatation at the LAD, and then deflation at the deflate of the 3-hole balloon, and immediately 3-hole balloon to deliver. This is a 3-spring balloon technique here. And the KBR, septal, and LAD. This is the final CG. So next theme is a 2 stent, provisional T stent or Kirotto stent, a DK crash. What to ask about side branch? Median classification is not enough because length of disease is a very important consideration for the side branch. Focal or diffuse, and the size of side branch, stentable, relative size to main branch, how much myocardium at risk, and how difficult will it be rewiring side branch is very important. And angle of origin is very important. Less than 70 degree or more than 70. This is a bifurcation curve that recommended. Bifurcation lesion has if complex 111 classification and access and or high risk of occlusion, interstitiation, Kirotto stenting or DK crash stenting is recommended. So DK crash 5 trial report as especially complex lesion, complex bifurcation lesion, the DK crash is better compared to the single stent kissing balloon technique, 1 year TLF. However, simple lesion, simple bifurcation lesion, there's no difference between single stent with KBI and the DK crash. So, however, LMT bifurcation is a unique bifurcation lesion. So, sideband lesion has more than 70% stenosis, and the lesion length is more than 10 millimeter. It means complex lesion, the bifurcation. In such a situation, 2 stent technique is recommended, the bifurcation curve, DK crash technique is recommended. So, most often used elective 2 stent techniques are Kirotto stenting or DK crash. So, however, side branch technique is decided wide angle range as a bifurcation lesion or narrow angle bifurcation is very important to determine the technique, stent technique. If wide angle, it means especially 90-degree T-stent technique is useful. So I explained the T-stent technique or tap technique here. So tap technique is here. First, the stent is deployed in the bifurcation while the wire, the side branch underlies it. The wire in the side branch is removed once and it is inserted through the strut and the KBI first. As a proliferation for final KBI, and while the deflated balloon is held in the bifurcation, the stent of the side branch is placed so that the ostium of the side branch is certainly covered. And the delivery balloon is inside the branch, is slightly pulled out, and the KBI is performed. Final KBI is performed during the bifurcation. This is a video from Telmo company, hot technique, and then recross for distal, and to deliver the balloon for the side branch, the balloon dilatation, and then final kissing balloon. And then to deliver the stent for the side branch. And the slight proximal position is in the LMT. This is a tap technique. Finally KBI and finally port. So advantage, simple. And but disadvantage, protrusion portion of the stent in LMT is no good. This is a tap technique. So T-stent techniques is very more simple, but the T technique is recommended. It's only bifurcation angle is 90 degree. This is a T-stent technique. First, single stent, the port technique, and then wire recrossing at the far distal, and then to deliver the balloon as a side branch, and finally kissing balloon inflation, the bifurcation. But if major dissection is occurred at the side branch to deliver the rescue stent for that the side branch. This is a T-stent technique. So advantage is simple and no metal carina is okay. But the disadvantage, the risk of a gap between two stents is occurred. It means if separated angle is large, the ostium of the branch is no covers of metal, the risk of ISR. Unlike curetto stenting, curetto stenting is the good advantage is full covered to the ostium of the LAD or circumflex. So this is a video. First, to put the stent LAD main branch, and then pot technique and guide wire recross far distal. Far distal is very important. And then kissing balloon technique. And then another branch stent to deliver the stent strut for the third branch. And the balloon dilation. And then kissing balloon technique. Here. And finally, pot technique. So this is a case, and bifurcation lesion and the LAD and the diagonal branch. IVAS cannot cross due to the severe calcification. So we use a squatting balloon, the NSC balloon 2.5 with leopard coronary technique. Balloon dilatation and the deflation immediately to push a balloon on distal side here and here. And then we dilate a two-hole balloon, squarex balloon, and the diagonal branch, and check IVAS marking at the distal center landing zone. But as you can see, major dissection occurred on the side branch, the diagonal branch. It means we put the stent, we should put the stent for the diagonal branch. This IVAS marking at the proximal site. So we put the 3 or 15 stent was implanted at the dissected diagonal branch. This slide is a CAG after stenting. So 3 or 15 NC balloon is a pot technique. After pot technique, wire recross to the LAD at the after LAD. After wire recross to LAD, 2.5 millimeter balloon dilation at LAD. And finally, first kissing balloon inflation at LAD and diagonal branch. And then 38 millimeter stent was implanted at LAD. This slide is CAZ after stenting at LAD. So report with 3-hole balloon at the proximal and LAD, and wire recross the diagonal branch with double lumen catheter support. So trapping technique to pull out the DLC catheter here. So I must check the wire recross point, but this case is no good recross point because wire coming. This is LAD and wire coming from here. First lumen and then wire coming. It means recross wire point is not far distal, it's proximal. Ideal recross point is first wire coming and then lumen coming. But this case is first lumen coming and then wire coming. It means not good recross point. But the diagonal branch is not large, so operator decided to keep on the procedure. Diagonal branch dilatation with 2.5 balloon and then KBI again KBI again at LAD and diagonal branch with 2.5 balloon and a 3.0 balloon. But finally, as you can see, this is the Z stand remain. It is not a good case. I was the same image. This is a bifurcation side. This is a Z strut at the bifurcation. It's not a good case. Here is Z strut. Z strut is the risk of what cause. I strongly recommend. So, two-stent curetto techniques advantage complete coverage of a bifurcation. But this advantage time-consuming and multiple rewiring and the case. And the cross point is very important. But this case is not a good case. The final technique is a DK class technique. Is very recently recommended technique. First, side branch stenting with minimal protrusion toward the main branch, and side branch stent crush with large balloon in main branch, and then side wire recrossing at proximal mid cell. DK crush recross point is not is changed at proximal mid cell. different from carrot stenting or one stent technique. Recross point is a proximal or mid-cell because crushed stenting. And then first kissing balloon technique, and then main branch stenting and the port here. And side branch wire recrossing again at the proximal or the mid-cell, and then kissing balloon technique again. This is a 9-step for DK crash technique. So there are 2 ports in an optimal DK crash here. First port and the second port is a DK crash. So second kissing balloon is very it's useful to avoid stent strut. If we perform DK crash with no kissing, as you can see, there is much stent Z strut. One step kissing has some Z strut. But if we perform a 2-step kissing, there is very clear opening the side branch. It means there is no stent Z strut. This is a DK crash technique from IVAS titanium company. First, side branch stenting, and then balloon dilatation at the main branch here, and then wire recross at the proximal or mid portion, and then kissing balloon technique, and then to deliver the stent for the main branch here. Yeah, this is a DK crash technique. So tips and tricks for the DK crash technique. Incomplete side branch apposition to avoid side branch stent apposition out of the carina is very important. This is a side branch implantation at 12 ATM. After 12 18, as you can see, around the carina, this is a malposition occurred. So to avoid malpositions occurred, additional proximal dilatation is very important, is needed. For example, 18 atmosphere. After 18 atmosphere, at side branch stenting, there is no malposition strut. So malposition strut could be corrected. It's very important. These are one tips. So some paper tell us good result for the DK crash stenting. This is a bifurcation lesion, 1-1-1-1, and including LMT lesion. So as you can see, DK crash, this is a crash with final kissing balloon technique. This is a crash without final kissing balloon technique. This paper compared the 3 groups, and first endpoint is freedom from TLR. As you can see, DK crash technique better compared to the other technique, DK crash with final kissing technique and without kissing technique, as you can see. So this paper is a DK crash 2, 1-year clinical follow-up as a true bifurcation lesion, at a true bifurcation lesion. And they compare the DK crash and the one stent technique is a balloon. As you can see, freedom from TLR is a DK crash better compared to the professional stenting. Freedom from TVR is good, and the freedom from MACE is good. So this is a DK crash 3 technique, and the same result for the 3 years is here. DK crash 5 is a very current paper. So 3-year clinical follow-up, DK crash is better compared to the provisional stent. It's a true bifurcation lesion, TVMI and TLR. And the stent thrombosis is very low at the DK crash stenting technique. And side branch FFR at hyperemia is better compared to the single stent technique here. So DK crash technique is commonly recommended, the true bifurcation lesion here. This is an ESC guideline. In true bifurcation lesion, the TK crash technique is better compared to the provisional T stenting. So advantage to stent crash technique, never lost access to the either branch and full metal covered at the carina here. So, but final kissing balloon technique after crash or crash stenting is very important. Kissing balloon technique, kissing balloon dilatation is a very important thing. However, stent technique, 2 stent techniques alert is here. Thrombosis rate is slightly higher without 2 stent technique. So, stent thrombosis is, we are afraid that stent thrombosis rate in that station. So this is a case, is an UAP case with a severe cash lesion around LMT. So as you can see, the severe stenosis at the ostium, the circumflex, and LAD, and the much calcification. IVAS tells us the severe calcification, the ostium of circumflex. This is the LAD coming from 7 o'clock. This is the ostium circumflex. Here, LAD coming from 3 o'clock. This is LAD, severe calcification, and the circumflex coming from 8 o'clock. Between the circumflex and the LAD, there is a severe calcification, same image. This is a schema, IVAS imaging at the bifurcation site. Between the circumflex and the LAD, calcification here is at the carina site. In such a situation, this is a true bifurcation. Guide wire, if I put the stent on the before without KBI before stenting, guide wire cannot cross at a far distal bifurcation due to calcification. But if we perform a KBI with both squatting balloon before stenting here, so around the plaque, around the carina, compressed with KBI. So after I put the stenting, guide wire can cross as a far distal bifurcation here. So we decide to put KBI before stenting with 2 squatting balloon NSE. These are 225 NSE for circumflex. And then 3 all NSE balloon, squatting balloon for the LAD, and KBI with 2 NSE balloon. And I check IVAS again here. So to compress here, to compress the plaque around the carina here, to compress the calcification between LAD and circumflex at the carina site. So we put the stent, LAD, and put the stent in the circumflex here, and high pressure KBI here. So this is the final IVAS imaging with expansion at the LAD here. And this is a circumflex here. So this is a good result here. So this IVAS imaging at the bifurcation before KBI and after KBI. So this is a true bifurcation calcification technique. I recommend the NAC balloon for KBI to create a space around the calcification site. And 7 French guide catheter is superior in such situation when complexities to stent strategy are planning. And especially, usually, lateral approach in the another problem for TLI, the large guiding catheter cannot use due to radial artery sides compared to the femoral approach. However, Thermo company sells glide sheath slender catheter. This is a very useful catheter for TLI. More with less. For example, 7 French catheter, this is a 6 French sheath available is 7 French guide catheter, glide sheath catheter. 7 French guide catheter can use in the 6 French glide sheath. So for lateral artery, usually we use a 6 French catheter, 6 French sheath. 6 French glide sheath is available for the 7 French guide catheter. So glide sheath slender is 5 French, 6 French, 3 types here. 6 French glide sheath is available, the 7 French guide catheter. It's very useful. So finally, I like to talk about the stent design for bifurcation lesion. Desired stent design for bifurcation lesion is large cell opening for branch vessel size, and at the most 2 ring stent, and a good scaffolding for shoulder at the branch vessel. So recently, intervention tells us side branch access is a cell area is a key point. Cell area is a key factor to achieve a complete apposition after side branch treatment here. So Ultimaster stent is a bigger cell area compared to the other major stent. Ultimaster stent has 33 meter square at the cell size. And 2-ring system as an Ultimaster stent. But another stent is at least 2.5 stent, 2-ring stent size. Less number of links may be available to reduce risk of side branch jailed. Jailed stent strategy is no good. It means 2-ring stent is better. Euro-intervention, as another paper tells us, Archimaster stent is opened at most 4.5. However, LMT size in some cases 6 meter or 5.5 or 6 millimeter. Archimaster size, Archimaster is no good choice for the LMT. Why? Really, over dilatation limit for each size is Archimaster 4.0 balloon, a 4.0 stent is at most 5.5 is okay. IFU update changed. 3.5 or 4.0 Archimaster size is 5.5 is okay. Actually, 3.0 Archimaster stent is at most we can dilate 4.5. But 4.0 Archimaster stent is 5.5 is okay. This slide is very important slide. Archimaster 3.5 or 4.0 Archimaster stent size is at most 5.5 is okay. So this is a stent appearance after over-dilatation for each stent. Archimaster is no damage after dilatation with 5.5. Stent design is still remained. It means lateral force at expansion limit is very important versus competitor stent. As you can see, Archimaster stent is very strong compared to the other stent at the expansion limit size. So another point, another important thing is the polymer damage is over-expanded. Archimaster is no polymer damage after over-tight expanded. Here, we have a drug delivery technology. So Archimaster is designed to facilitate the bifurcation stenting. Expansion cavity is okay, and the side branch access is okay because two-link stent. And the reliable drug delivery technology accepted the Archimaster. So in conclusion, bifurcation stenting, to consider the possibility of presence and the extent of gel strut malposition is very important to improve better clinical course. Stent strategy is a one stent or two stent. Here, the stent procedure technique is very important before stenting. Guide wire recluse point. Usually, for distal imaging is useful. Tips of a POT or KPI, I explained. Two stent strategies, DK crush or close stent, are recommended. Ideal stent design is a two-ring. This means flexible and low risk of zero strut remained, and the large expand is at least 505 millimeter, and the reliable drug delivery technology is ideal stent design. Archimaster stent is reasonable choice for bifurcation lesion. Thank you for your attention.